Faith Forward Media, this is Healthcare Musings. I'm Dr. Hashem Hasabala. Welcome, everybody, to Healthcare Musings. I'm so happy to have you with me. I'm honored and excited and super delighted to have Scott Becker on the podcast. He is founder and publisher of Becker's Healthcare. If you want to understand the healthcare field, you need to subscribe and need to follow Becker's Healthcare, because they have on everything and every aspect, on hospitals and physicians and leadership and the insurance space and the ambulatory space and everything. And so, given as part of this series of great minds in medicine, I wanted his perspective, because I think he has a perspective of 30,000 feet, like the air tower, right? You see everything, and I wanted to get his insights into where healthcare is and where he sees it going. And I think it'd be very helpful for me, first and foremost, and my audience. So, Scott Becker, so happy to have you on the show. Welcome.
Well, Dr. Hasabala, I am so thankful to be here. Thank you so much for having me. I know over the last few weeks we worried about a government shutdown with the air traffic controllers and so forth. So I hope that we're past that, and that my thought of being at the top of looking at the air traffic control won't be totally off. But at the top is a vast misstatement. But we try and see it like everybody else does, both from watching it closely. And one of the beauties of healthcare is you can't fool anybody, really, because we're all consumers of it. And you could say all you want about cost, but we're getting insurance bills this year. We know they're going up. We see that. And when we talk about access, we also all see the same thing. It's harder and harder to get to where you want to get to the right physician, the right specialist, the right everything when you need that person. So one of the beauties of healthcare is, even though I might have a view from observing it and watching it, every one of us is a consumer, so all of us share so much in common when we think about the core things of quality, cost, access, and what it looks like. But can't wait to dive in with you, and thank you so much for having me on.
Oh, absolutely. Thank you for being here. It's such an honor for the show, and an honor for me personally. And we were interacting on X, and so I thought I'd ask, and I was shocked that he said yes. I said, hey, I'd love to, because I met one of my hospital clients. I met them at the recent CEO CFO summit at Becker's. It was a cool vibe. It's the first time I had been there. I had been invited in the past, but I'm always working clinical, so wouldn't been able to do it. This time I met him there. It was really cool, and I had reached out to him on X about that, and he was very gracious in his response. And so I thought, well, let me try to take advantage of the grace and see if he'd come on, and here we are. So I'm very, very happy to have you. Let's just dive right in. There's so much insight when I get your newsletters, and you just tell us what's happening, like what's going on right now. And so where do you see, with everything that's happening, from your view of the current state of the American healthcare system?
Sure. No, it's a great question, and I think you've got these. You have to look at this. I sort of take a step back when I look at this, and I say we're the third largest country in the world after India and China. And India and China are 1.5 billion each in people. We're about 350 million people, depending on what date is. And so the first thing that I sort of think about is what a challenge it is to actually provide health care for 350 million people. That it's sort of, when people say, like, well, Norway's got a great system, but they have 8 million people, or the state of Maine is fantastic and they have 1 million people, you're looking at very different animals. And so when I look at this in total, we have huge challenges. We're in a lot of ways far better off than China and India, which almost have insurmountable problems on healthcare at 1.5 billion people. And that's not a negative on them. It's just almost an insurmountable problem to take care of 1.5 billion people. We think that our ratios of physicians and nurses to population are horrendous, and they're getting worse. And in subspecialties, they are horrible and getting worse. You compare it to many other places in the world, we're in contrast quite fortunate. So sort of when I look at healthcare as a whole, it is very challenging. We do a lot of things right. It's very expensive, and we have daunting problems in terms of coverage being one issue. We'll talk about that a little bit later, but just in terms of quality and access and cost, all of those are seemingly going a little bit in the wrong direction at a time, and some of them more rapidly than others. So when I think about quality, cost, and access, there used to be this concept we talked about in healthcare often, that it was easy to get 2 out of those 3 right. So, for example, there was always this discussion: you can get cost down and access improved, but you would sacrifice quality, or you can get quality up, but costs would go high, and you might sacrifice access. But what's really happened now is access slash supply and demand and quality are now so tightly tied together that as we don't have enough access, it's very hard to have enough quality if the workforce and the people that take care of us are overwhelmed. So what I see in a general rule is, or general world is, yes, we're better than some of the larger countries in the world. We're not as good as some of the smaller countries in the world. There's no way we're going to be. But at the same time, I look at it and think that we're moving in the wrong direction on all of the three big things we always used to talk about, which are cost, quality, and access, and not to mention coverage. And the reason I take coverage aside is I think most of us in healthcare are believers, one way or another, that we should have coverage for all. But coverage for all, and that doesn't make me a Democrat or a Republican. It makes me a believer that we should have coverage for all. But
Hmm.
coverage for all, and this is one of the key problems in our politics, is completely different than quality, cost, and access. And so, while we want coverage for all, one of the things we always talk about is the politics are sort of broken in our country, and you've got two different big pieces of this. You've got coverage for all, and I think most of us, whether you're a Democrat or Republican, no matter who you are, it comes to the conclusion that we should have coverage for all. But coverage for all is completely different than actually delivery of healthcare. Delivery of healthcare, I think about as the three things we've always talked about as pillars: quality, cost, and access. And the reality is we need to address these as almost two separate or connected issues. Yes, we want coverage for all, but if you hear somebody say we want coverage for all, but they're not addressing quality, cost, and access, they're really doing a disservice because they're doing a political commentary about coverage for all, and we want coverage for all, but they're totally failing to miss the core issue of how do we address quality, cost, and access. And I think if there's a fault to Obamacare or the ACA, it moved towards increasing coverage, but did nothing to solve the real problem with delivering health care, which is quality, cost, and access. And I applaud Obamacare, the Affordable Care Act, for getting us down to only 10% or 8% who are uninsured. That's a good thing, not a bad thing. But then if you do that but don't address quality, cost, and access, it's like the glass is half empty, which is really what we're at and we move to. So we have to figure out a way to address the true delivery of healthcare, not just the coverage discussion. And it's a fault of the left and right. I blame everybody, but we need to get to quality, cost, and access, and how do we really improve those things which are fundamental to our, and I have very serious thoughts on them and strong thoughts on it. We'll get into those, but let me turn it back to you, Dr. Hasabal, and we'll come back to,
No,
to
that's very good, and it's a really great way to frame the two sides. So we can let's talk about quality. You can get top-notch, world-class healthcare here in the United States. And when I travel abroad for on vacation, I pray that I don't get sick because the quality of healthcare is not the same, right? And I worry about the quality of healthcare, even if perhaps the physician may be qualified, just the whole or competent, it might just be the whole system worries me quite a bit. And when you look at healthcare outcomes compared to, you were saying, Norway or Sweden or anything, we're lagging behind, even though you can get top-notch healthcare. So why is that? Why is it that when they rank us, our outcomes, or are they even the right outcomes to measure?
yeah, no, I think they're great questions. I mean, you've got this challenge of, I think it's almost impossible to compare us to Norway, Sweden, these other countries for a billion different reasons. We're a huge country. We're 350 million people, and it's a very different thing delivering 350 million people that are very heterogeneous, that are all over the place. They're all over the place in terms of income, resources, social determinants of health, which is a very different situations than do a lot of these other countries. And that's not here nor there. But to address this, one of the things about, you said something about quality. There are certain countries where you're happy to get sick in, other countries don't want to get sick in, and the inequalities all over the board in terms of those countries. In our country, quality also is all over the board, depending on which community you're in, which city you're in. If you're one of the top 20 metro areas, you should have um, some critical mass of great healthcare, great doctors, great nurses, great specialists, if you can get into them. Different issue. If you
True.
get into smaller communities, and this is something that's happened in our country for the last 30, 40 years, is more and more specialists, more and more doctors have gravitated to our top 10 to 25 metro areas, less and less in the smaller metro areas, and so harder and harder to get the quality of care you want in the smaller metro areas. Now, in terms of taking the next step on quality of care, one of these you find you're at one of the most elite academic medical centers in the country, and which does an incredible job. Rush is an incredible place in terms of hitting two different efforts of both being an elite, great academic medical center and under Dr. Latif's leadership, also trying to really take care of that West Side community, which is a
Hmm.
very low income community that has lots of healthcare needs. So, and he talks about the zip code crises where, two zip codes away, people are living to 70, and in the zip code area you're in, they're living to 50 or 55, whatever the
That's
number is,
which is crazy.
which is crazy. So what happens is, even with the quality that we have in our country, what you find more and more, and even is, and not talking about Rush, but you talk about the top academic medical centers in the country, where you might have the best quality of care in a certain subspecialty. What you find increasingly is that the bench at these places is shorter and shorter and shorter than it used to be. So when you have somebody that's got a serious disease, a serious problem, one, you have to find access to the right person. Two, you find that that person is not supported by the type of bench that you would hope or expect. So when somebody had a horrible sort of eye cancer, there's 3 eye specialists in the country that work with that issue, and once you get past those 3, you're in trouble. And getting the time and energy from those people is very, very hard. So even though we have elite quality, I would argue that at too many places, taking aside Mayo, taking aside Cleveland Clinic, taking aside a handful of places, the veneer is prettier than the depth, and that's a problem. And what that means is, whether we're moving towards a spot in our country. We've always known that there's 2 tiers of care. There's people that are Medicaid and impoverished, and then there's the rest of us on commercial insurance of some sort of another. I mean, and anybody that says differently about that there's not 2 different tiers, I think is just really missing the boat, because I think there very much is. I think if you're Medicaid or poor, you've got less access, less ability to get the right providers, less connections to get the right providers, and so forth. And what you're moving towards rapidly in our country, and a lot of it comes back to this issue of intense shortages in specialties, subspecialties, and everything else. You're very quickly moving towards multiple different tiers. It used to be 2 big tiers: those that are commercially insured versus those that are Medicaid. Medicare was somewhere in between. The totally indigent and poor, even worse. Now you've got, amongst the commercially insured, or people that make a living community, whatever you want to call it, you're now dialing into multiple different tiers there too. So, for example, if you are in many states, you can't get a primary care doctor without paying a concierge fee. And those concierge fees are expensive. So now you're
Yeah.
looking at a different tier. The sort of the top 10% in income are getting concierge. The next 50, 60% are not, and then 40% are in government healthcare. It's what you're moving towards is, in every area, more and more different tiering of our healthcare system. And a lot of it comes down to, at the end of the day, horrendous supply and demand problems. And we'll dig into that more deeply in a second. But if you look at our country and say 40% of healthcare is paid by the government, Medicaid or Medicare, and then you've got 60% is commercial or privately paid. And I think now something like 30% of 30% of the healthcare dollar is paid by patients directly. So some
Hmm.
insane number today compared to years ago. But either way, that 60% fits in one bucket, Medicare, Medicaid fits in another bucket, and you could divide Medicare, Medicaid, indigent. You've already got multiple tiers, but the tiering on the commercial side is getting far worse than it was, and it's going to get a lot worse. And it really comes down to, you could talk all you want about coverage, but if we don't get supply and demand in balance, this is just going to get horrendously worse. So
Well,
that's the next point that I have
no,
for you.
and that's a good segue into the thing of cost, because as a clinician, right, as someone who provides the care, I'm still actively practicing medicine, and happy to do so. I resent the finger of cost being pointed at me. right?
Right.
So Adam Seafield at the University of Chicago had a great piece about why he sometimes doesn't answer right away his messages. He has to think about it. He needs time for himself. There's so much to do. And this week on the podcast, I talked about why the New York Times had an article about AI chatbots and people going to that, and then why, because they're frustrated by waiting 3 days for their primary to respond. And I have the same frustration, and we have to deal with that. Well, the finger is always pointed at the cost finger is always pointed. I feel, and you tell me, at the provider. I hate that word, but at the provider, right? If it's Medicaid, there is a two-tier system because frequently the Medicaid doesn't reimburse physicians and hospitals and where it's still a business, right? No other
Right.
business would be forced to run at a loss with every single government healthcare patient, right? Every hospital loses money for the most part on Medicare and Medicaid patients. Hospitals are the only 24/7 business. Doctors' offices aren't. And when I was in private practice, now I'm part of a large multi-specialty group, but in private practice, the reimbursement kept going down every year, but our costs didn't. Healthcare didn't. The lights don't. The toilet paper doesn't. So it's an unsustainable formula. And then the finger is, oh, well, you doctors in America are paid way more than you are elsewhere, which is true. And we have 500,000 plus in debt coming out of school, right? So
Yes.
I resent that finger. I wanted to get your thoughts about that.
Yeah, no, 100%, 100%. The pointing the finger at the doctors is so abominably wrong. It's hard to even fathom and discuss it with logic. It's so insane. We're down to about 1,070,000 practicing physicians at most, out of a population of 345 million people. We've sort of lost the battle on primary care directed physician care. I just think there's any way to get back to that. I'm fortunate my primary care doctor's been with me since I was 22 years old or so. But when he retires, I don't know where I'm going for primary care. More and more of everything's transactional. So there's just not enough doctors. There's just not enough
Yeah.
doctors and nurses. So blaming it on doctors and nurses is so obtuse. And it's almost a political establishment and political narrative benefit in doing so. What's really happened, and it's very unpopular to talk about, but we've ended up with the same problem in healthcare and in education in our country. The more that the government has subsidized healthcare and has subsidized education and subsidized the patients, what we've led to is a huge military industrial complex in education and in healthcare that has benefited certain groups, to be large educational institutions, large insurance institutions, and it has led to this disaster where the cost have gone up because we've got so many different middle people in the system that have been sort of um, insulated and inflated through government subsidization that has led to a spot where we've got more education debt for people than we've ever had before. You get more and more people going broke from their education debt, not just at the med school level, at every single level of
Yeah.
education. And you've ended up with these huge college institutions, universities, and so forth. And you can't disconnect the two. People have to make the effort to connect the dots and all the stuff. When President Biden says we got to give people education relief, I don't disagree or agree. There's obviously lots of complications to it because you had people pile up tremendous amounts of student debt. There's a whole generation of people that paid off their student debt. So I don't have an absolute, but what I can agree with, student debt is a problem. But you can't look at student debt in a vacuum and say that the education system and institutions not a problem too. What's happened is we've led to a spot like when one of us from my generation says to the kids, well, I paid my way through college. It's true, and it is true, but the
Yeah.
cost of college then was nothing compared to what it is today. We've
Very
ended
true.
up in a situation through a ton of different subsidies, a ton of different circularity, increasing the cost of education to an insane amount. And you have to do both. You've got to cut the cost of education while cutting the cost of debt if you want to cut student debt. But it's sending in healthcare. When I see this argument on subsidies, right now, President Trump and the Democrats are involved in this discussion about ACA subsidies and what to do about them and how to contain them. The subsidies are obviously a band-aid to a system that's become incredibly expensive and incredibly insane, where so much of the money flows through to insurance companies and everybody else. And so what happens is if you are poor and get a subsidy, you want that subsidy. Or if you are lower income and get a subsidy, you want that subsidy, and rightfully so. But by giving the subsidy, and I'm not against giving the subsidy, but we fail to address the problem of how do we get to that spot where that subsidy has greatly increased the size and strength of the insurance companies and everybody else, and at the same time left more and more of us with healthcare that's crazily expensive. I mean, obviously, if you are on a healthcare plan today, the costs have gone up. I can't even believe what we're paying for healthcare now for our family compared to just a few years ago, and they're going up
No, it's
again.
tripled for me. It's more than tripled.
Yes, and they're going up again this year by a significant amount. And I think the people that get subsidies don't want to understand that those that aren't getting subsidies and aren't paying 30,000 plus a year for healthcare, which is an insane amount. And it's not that they shouldn't get subsidies. I'm on board with getting subsidies, but we have to fix the core problem through the subsidization of everything, healthcare, education, and other things. We have increased the cost of those things by insane amounts. And that is an unsustainable thing that we have in our country. And what it does is, for example, if you're on either side of the table on this and you talk about the subsidy issue, you're not addressing the core issue, which is ultimately supply and demand. Do we have enough people at the right cost, the right place to take care of our people? And for 345 million people, an aging, graying population, people that live a lot longer, we're in a horrible situation on the core problem of supply and demand, which leads to quality, cost, and access. And I'll just give you two examples. So we get a chance on the Becker's Healthcare podcast to talk to physicians, leaders, health system leaders all the time, every day. One of the things that strikes me is, so on the phone with a neurologist in Texas, and we all recognize we're in a time of hugely increasing dementia, Alzheimer's, and other things. He is the one neurologist in about an area of about 700,000 people. And then on the podcast last year with a dermatologist in northern Minnesota, obviously a very Scandinavian state, and she's the one dermatologist in an area of 600,000 people. And those numbers just don't work. And you could look at all the AI solutions, all the technologies. We need them. We need all the advanced practitioners. We're doing a great job in our country of increasing the pool of nurses from where it was a few years ago. We've made tremendous strides in improving that. What we're doing a horrible job is increasing the number of specialists in our country, and we have to solve that because at the end of the day, there are a lot of things that can be done with a lot of technology, a lot of people, and at the same time, we need the best and brightest in the most complex areas to be able to really solve problems and take care of people too. And we got to try and figure out a way to solve that too. But you've got this burdening issue in our country. We've got horrible shortages of specialists in lots and lots of areas, and it's going to get a lot worse.
Well, that's a good point. And I'm telling you, it's hard to get in. My daughter is in med school. Thank God. She's now a second year at the Chicago College of Osteopathic. I'm so happy. It's impossible to get in. It's even like when I took the MCAT today, I would have failed it, right?
Yes.
It's such a hard, they make it so hard to get in. And on one hand, I don't want immature teenagers going into med school. I mean, there has to be some sort of maturity because it's a tough field and you need resilience. And at the same time, it is so hard to become a doctor and so expensive. And then their solution is to then limit the amount of money you're going to borrow. So now you're not talking to the institutions to cut down on tuition. No, you're just saying you can only borrow this much from the government, which I had a podcast about this. It's such a poor, it's penny wise and pound foolish. The investment that you can put into a medical student like me, I've paid the government back, I don't know how many X, right? It's just so hard to become a doctor.
It's a very, very complicated issue. You've got 50,000 people apply a year, 20,000 get in. It's become incredibly bastardized. We know a lot more doctors. We need a lot more doctors. Access is horrible. And at the same time, we don't have nearly enough residency spots to let more people into medical school. The reason why we don't have enough medical school spots because people want to build medical schools and medical schools are being built, but you've got a problem because now you got 5% of med students, 10% of med students aren't matching into residencies because in certain areas there's just not enough residencies, especially the ones
Right.
that people want to go into. So you've got this horrendous challenge of the med schools have no choice but to make it hard to get into, and that's become very bastardized too in admissions and so forth, as we all know, for all kinds of different reasons, good and bad. I mean, we need a very diverse population of doctors, and we need to make sure that we got the best and brightest doctors and hit those two in the middle. Then we need enough residency spots to take care of that. But yes, no, it's absolutely, and in the cutting down of government debt on it and how much they'll extend debt, there are two sides to that issue. I agree with you wholly because this makes it harder and harder for poorer people to go to medical school and anybody to go to med school because it's incredibly expensive.
I can't afford to pay medical. I can't afford to pay medical school bills for all my kids. There's no way. There's no way.
A
You're,
hundred
you're
percent, a
talking
hundred
about
percent.
millions of dollars.
But one of the challenges that we have is by the government improving and increasing all these loan programs, we end up inflating the cost of everything too. Because what happens is if the medical schools understand, the universities understand that the government's backstopping everything, there is no sort of control on the cost increase of medical schools, universities, colleges in our country. So it's a complicated issue. And again, we all want to make sure that there's access for the best and brightest, poor or rich, to get to medical school, that they have the ability
Agree.
to do so economically. We want it and we need that, and we want the best and brightest to go. I mean, we ultimately need more things like NYU did, which is to make it tuition free, to move this in a situation where it's not so insanely expensive. So I hear you. One of the challenges we have is when the government loans money to everybody to do everything, then it allows the institutions that charge people to not be efficient, but to essentially increase the cost of what they're doing. So it's all passed through from the government. It's very much like the insurance industry. We've got this situation where we're now up to literally, I can't even tell you, I think my individual family insurance right now, family insurance is about $3,500 a month now through our firm, stuff like that, which is an insane
Oh
number.
my God! Wow.
It's
Really?
like 3,000 to 3,000. I'm in whatever. I'm 61, but yes, but we still got two kids on the insurance, and until the last one gets off, it's still very expensive, and it's insane. And it's and part of it is we've got this entirely bastardized system where the government subsidizes a lot of stuff that goes to the insurance companies, and then the insurance companies charge what they charge, and they're in a horrendous situation too. I mean, they're not having they had it easy during COVID when they've collected premiums but didn't do care. They don't have it so easy now. The health systems have it very hard. They've got increased labor costs, increased everything cost, and then trying to keep cost reasonable. And they've got exactly the problem you talk about. They've got largely a fixed revenue or reimbursement per patient, but they've got the cost, like you mentioned before, the cost of everything around them going up. So
Hmm.
in any way, shape, or form, the businesses that people want to be in, we always talked about in business, you want to be in business where somebody is being paid through other people's money. And that's a phrase that we're all familiar with, other people's money. So if I'm by background a lawyer. You follow me?
Yes.
If I to work for you as a lawyer, I don't want you as a client, and bear with me on this, because you're spending your own money. So unless you're a careful consumer. You follow me? What,
Yep.
what you really want is a company spending money, because now Dr. Hasabala is not spending his money, he's spending X's money. You follow me? And it
Yep.
just means it doesn't, not good or bad, but it means, if I do work for an individual doctor, he or she, and I don't do this kind of work, I used to do it, but he or she wants to spend $2,000 for 50 hours worth of time. And it's
Hmm.
not wrong, but it's their money. It's very real to them. And what we've created in our country with education and healthcare is everybody is always spending other people's money. So we've ended up with an incredibly bastardized, very expensive system because the whole game is other people are like, what if I am paying for medical school to a university and I don't have the government subsidizing me, then the university or med school has got to be careful what they charge me. If I'm not really paying for med school, but the government's lending me 300,000 to go to medical school, now the student's sort of screwed because they want to go to med school and they don't think about the 300,000 in this moment, although they might. But now the university could charge 300,000 because they know it's not really that student paying it. That student's getting money from the government to pay it. So you've ended up with this completely bastardized system. all throughout insurance, all throughout healthcare, all throughout education, where everybody is spending other people's money, other than those that are wealthy enough to pay directly, and nobody has empathy for that, nor maybe they shouldn't. I don't know if they should have it or not, different question. But you've
Right.
developed a whole system based on other people's money, and it's inflated the heck out of everything, and so it's a disaster. So the subsidies, they're not right, they're wrong, but they do cause us to have an inflated system. And that doesn't mean we don't need them, because we need poor people to get health care. And the med school cost, capping the amount that the government will loan a student for med school, not right nor wrong, but you have to recognize there's two sides of it. If we cap it, it makes it harder to go to med school. If we don't cap it, it means that the med schools can charge whatever they want, because the student doesn't think they're paying it right now. And then the student is up 5, 10 years from now, like we've had this whole debate over student debt repayment under President Biden. Again, I have lots of empathy for it. People have taken on a fortune in debt. They've ended up with a job market that's much tougher than expected. They often got degrees in things that aren't valuable. And so you've got this horrible, horrible situation. At the
Yeah.
same time, if you're my generation or your generation, we took on these debts, we paid them down, but the debts weren't often nearly as big because we didn't have such an inflated system. So I don't know
No.
I don't know the exact answer to it, but it's a debacle. I mean, it's truly a debacle. And the more that you have the government subsidize everything, and this is not a right wing or left wing thought, it's a reality of economics. The more that the government subsidizes all of education and healthcare, the more that healthcare and education, medical school and education, has carte blanche to charge whatever they want to charge. And they've got tons of, if you go to universities, wonderful places, critically important to our ecosystem. We need the best and brightest on our universities. We need the best and brightest teachings, but we still need accountability and control of economics. So it's a long-winded answer, Dr.
That's such an
Hasabala.
important that's such an important perspective. I mean, it's I didn't think of it that way. I know that the proponents of capping it do it that way, and just like you said, it's a very difficult situation. So we talked about cost, we talked about access, and now we talk about, and our quality is going down. So what's your okay, so these are things. You're looking at from your perspective, what are good solutions? Like Dr. Latif he and I trained together in the same year at Rush. We were in the same class, fellowship
Yes.
class. So that was really nice. He's a really good friend of mine.
Ugh.
He talks about being a second paragraph person. Okay, so what's your solution?
Yes.
What's your sense of what can be done, or practical things? I had our president of Sound talk about how payers and providers is this intractable conflict, and maybe we have to learn how to align incentives together and have more of a value-based system where you're not being paid for sick care, you're being paid to keep people well. You're going to always need, thank God, we're going to, as sad as it is, there's going to always need people like me, critical care specialists. People are going to always be sick. There's going to always be a need for very complex sick care. And the more we keep people healthy and be incentivized to do that, the better for the system. What are your thoughts about that?
Yeah. No, I think there's something to be said for that. I do think I'm a believer in what we call trust but verify. And bear
Yeah.
with me on this. The concept is, all of us think that preventive care, that technology, that a number of other things will help solve some of our healthcare problems, that enough technology, the right prevention will help. That's trust. But my belief is we better verify too. So as much as we double down on prevention, which I think is very, very hard in a country of 345 million people, it doesn't
No
mean that we
doubt.
don't need everybody to get, their colon screenings, their breast cancer screenings. All these things are really good and really needed. And I'm a big believer that we need early childhood vaccinations and so forth. And the war on vaccines is so maddening to me. So
Yeah.
the concept that prevention is very, very important. Technology is very, very important. But we better create enough doctors and nurses to make sure we can actually take care of ourselves as well. And then I've got, relatively strong thoughts there. We've got to increase the amount of residency spots. We've got to have more, we almost, it's a very unpopular thought. We've almost got to give up on the concept of the primary care physician like Marcus Welby and realize that we're moving towards advanced practitioners, PAs, nurse practitioners doing the lion's share of primary care. Because if we have about 20,000 residency spots a year, and we got to get that to 24, 28, and my numbers are very approximate. We have to make sure we've got about 15 to 20 now, 18,000 a year or so. We have to increase that by 4 to 8 to 10,000, and then a lot of those spots, they already argue that we're 100,000. Some studies will show that we're already 200,000 short primary care physicians, and we only create about 10,000 primary care physicians a year, and about 10, 12,000 physicians retire a year. So to give you those numbers again, 18 to 20,000 residency spots, 10,000 or so physicians retire a year. About half the residency spots go to primary care in one way or another. We are so far behind on primary care that no matter what we do, we're not catching up to have primary care delivered by doctors. And again, the places where you have primary care delivered by doctors, my doctor retires, I got to find a concierge doctor. I might have the means to do it. Most people don't. So most of us are moving towards this transactional nurse practitioner, PA type thing. They're often very, very good. It's not nearly as good as senior primary care that you know and visit with twice a year. But
Right.
I think that is basically, I think that war might have been lost already of getting us to a spot where enough primary care doctors in our countries and enough interns in our country. It's a way that we all grew up. We think it's fantastic. We just think that war might be lost. But what happens now is as I age, and you see so many people with cancer diagnoses, with other challenges, obviously heart disease and cancer are the two biggest killers of people over a certain age in our country. Those are the two biggest killers in our country. And in total, we
Yep.
are so short oncologists, cardiovascular specialists. We are so short psychiatrists and social workers. We're so short in behavioral health. We are so short in key specialties. We're so short in dementia and neurologists and so forth. We are so short in specialists. And if we don't start to address that, it's unpopular to address because, again, it's your narrative on doctors are at fault. Doctors are the problem. And so what happens is when you go to Washington, any doctor that makes over a few 100,000 a year, which is often specialist, is viewed as a bad person, the demon, a devil. And at the end of the day, it's when you have a medical problem of a serious type, you need those people. You need
Yeah.
those people. You might be like, oh my God, they're making so much money. And of course, that those doctor specialists feel like they're not making as much money as the finance people on Wall Street, the technology executives, everybody else. They're irritated themselves.
Yeah.
And I don't know what the right answer is, but what I do think is when we try to solve this problem, technology, prevention, all great. China and India rely heavily on prevention, and it's largely a disaster. So to think that we're going to get through prevention as a huge country is like, it's nice. RFK says we all got to get everybody running and walking again. And we agree with all that. We just don't think it's solving our problems. So trust but verify means we better address the shortage and the ongoing shortage of specialists and subspecialists in our country. And unfortunately, it takes years to do so. We've got a medical education system that is broken. You've got a daughter in med school. I've got a stepdaughter in med school. It is a broken system. It's a broken system. It creates great doctors, but it's a broken system. It's 4 years of med school. It's 4 years of residency. It's a year or two of fellowships. People aren't practicing until they're 31, 32. So then they're, a huge percentage of doctors are going part-time in terms of clinical work by 40, 45. So now you've got this horrendous situation of doctor hours compared to our population that's a disaster. In other countries, and we are the beneficiary of this, they finish, some of those doctors are fully practicing by 28, 29, 27, those ages, and we are the beneficiary of it. So people say to me like, oh, they're not good doctors. Well, the best doctors that I work with up here are often doctors from those places, from those countries that got out of school and were totally done with residency and fellowships by 28, 29. I mean, so you can't tell me we're doing it wrong because some of our best doctors in the country are from other countries where they finished their education entirely and we're out practicing entirely a few years earlier than we are. So the medical education system is broken. We've got to fix it. It produces great doctors, but it does so incredibly inefficiently at a very high cost. And you know how our stepdaughter is a third-year medical student. Yours is a second year. You know how hard they're working. They'll go away for rotations. They work their butts off. They have very little
Yep.
time off. They have peers that are making a lot of money, having a lot of fun, and they're working their ass off. And it's just messed up. And they're great kids. So and I don't look at it through that lens. I look at it through the lens of with this horrible shortage of doctors, other medical education in our country. And tell me, Dr. Hasabel, when I'm just going on too long, and just shut me up.
No,
In
no,
other
no. That's
countries,
awesome.
that we are the beneficiary of, they got like in India, a lot of people are going to medical school right out of college. So by the time they're actually practicing, they're 27, 28. At my local institution, the best hip doctor at the local institution, the best knee doctor are guys that came from that culture, that came from that country. And it's not that country itself. There's lots of countries like that. But the concept that we are stuck in a medical education system that was developed prior to the internet is just it's ludicrous. I mean, it's incredible how the beauty of nurse education. So here's a great stat for you. Nurse education during COVID, we went down from 5 million to 4 million nurses a year. And we went down. Nurse education had a stopgap, a limiting problem. We couldn't produce more than 150,000 nurses a year because of various different reasons and so forth and so on. That was solved, not overnight, but it was solved very quickly. We're back to producing about 180,000 nurses a year. 185,000 nurses a year. We're still stuck at producing about 22,000 doctors a year. I don't know the exact number, but we solved that problem. It's not that it's solved entirely, but that nursing shortage is much less acute than it was a couple of years ago as people came back to the workforce and as we made nursing education just a little bit easier. And some people will complain. Senior nurses might complain, oh, they're not coming out as educated as they were. They're not this or not that. But thank God we're producing 185,000 nurses a year. Now, to add a follow-up problem to this, because we're producing 185,000 nurses a year and we don't produce 20,000 doctors a year, and we are so short in what we need in terms of doctors, you're going to get into a situation where just by default, so much of our care is going to be provided by nurse practitioners and nurses and PAs and everybody else, because that's where there's resources. And so my view of this is trust but verify, rely on nurse practitioners, rely on advanced practitioners, rely on preventive medicine, rely on technology, but we got to produce enough of the best and brightest doctors in all these specialties for us to have a great system going forward.
That's a good point. And it is hard. I think medicine is still a guild where the learning is in the work. And I worry about shortchanging the learning. Like when I graduated medical school, I was a very dangerous doctor. I'll tell you that. I didn't know what I didn't know. You need every patient encounter is your teacher. Every time you see a patient, you learn. And it's a guild. It's still a guild where you gotta be an apprentice for a certain amount of time before you're able to go and be signed off to go on your own. It's you can't just be an online doctor or an online nurse. I don't know how to fix that 100%.
Problem. But would you really lose out if we cut a year out of medical school? How much a difference would that make? Because you're still not you're taking away some of the rotation time, but you're not taking away the 4 years of residency or 3 years of residency. How do you keep that, but sort of take away some of the school time? I know in the law field where it's a 3-year degree, you're done by the end of year 1 or 2 doing anything that's relevant to actually practicing law. And medicine's different because you actually do have hands-on experience in medicine, which is fantastic. But how do we keep a lot of that?
That's a good point.
So much of medical school is still rote learning, and it seems like with the internet and stuff like that, we could cut some of that down.
No, that's actually very true. Do the preclinical years have to be 2 years, right? And does it have to? Can it be shortened, or can you go right into it? Yeah, no, that's a very good point. That's definitely food for thought.
Yeah. And how do we cut it some? We don't have to cut it in half, but how do we get it from what's become an 8 to 10 year process on top of undergraduate to a 6 to 8 year process, or whatever the number is? I mean, we're doing it in some other countries, so it's doable. It's better figuring out how to do it.
That's a good point. That's such a good point. I could talk to you for hours and hours about your thoughts. This was fantastic. You had a lot of food for thought. Definitely have to have you to come back and talk more. Scott Becker, it was really an honor and a pleasure to have you, and more to come here. Thanks so much.
Dr. Hasabala, a total pleasure. Thank you so much for having me. We'll get a chance to visit with you again soon. Thank you very, very much for having me.
Take care. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.